Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA. In this series, we are trying to explore the world of hematology through conversations with leading experts in the field. Today, we are thrilled to have Professor Brian Huntley, head of the Department of Hematology at the University of Cambridge. Professor Huntley is a renowned clinical research scientist and consultant in hematology at Addenbrooke's Hospital, and he's known for his groundbreaking work in leukemia stem cell biology. Thank you for being with us today. So, to start off, we would like to learn where your journey started. What is your first memory of hematology?
Thanks for inviting me. It's very nice to be here. My first memory of hematology was as an undergraduate. You learn all about body systems, and I think even at that time, blood kind of fascinated me. Because of its accessibility, you can take a tissue sample from literally a blood test. Many of the sort of basic biochemical principles were worked out in blood and blood cells. And that kind of subliminally stayed with me and was one of the reasons that I wanted to take it up as a clinical specialty, this mix of science and clinical medicine. And then I think it was one of the things that directed me towards a sort of career in science.
Because you are a trained medical doctor, and then you have been doing research and translating that research always to clinics.
Yeah, I mean, it's a sort of circular route. I wouldn't say that my trajectory and my path was a classical one, because I didn't do much science until I had trained and specialized as a hematologist, and then I decided I wanted to try and do some medical science. So I did a PhD, and then I've not really looked back. But it certainly was the application of science and the sort of basic mechanisms that were much better studied in blood disorders and in other disorders that made me decide to be a clinical hematologist. And then when I was studying for my postgraduate hematology exams again, I wanted to explore the science more. So that's why I decided to step back from clinical medicine and to pursue a PhD.
And what led you to focus on leukemia and stem cell biology?
Yeah, I mean, I think that as a practicing hematologist in the UK, your practice is dominated by malignant hematology. And to my mind, not only is it the most common problem, it's the most intractable problem. And it continues so this day. I mean, I've been a researcher in hematology for 25 years, and I'm embarrassed to say that we have improved the field, but we still have a great deal of work to do. And the things that you remember are probably more your failures rather than your successes. And I study predominantly acute myeloid leukemia, which is a very, very aggressive disease, and we still do very poorly in terms of the numbers of patients that we cure. However, we do cure a good number of younger patients. So it was interesting, it was difficult, and we weren't really doing very well. So that was the reason for sort of gravitating towards leukemia biology rather than studying blood coagulation or red blood cell disorders, which are equally interesting, but in my practice were just not as difficult problems, and I felt that there was more needed to be done in those than in other areas.
So your research has had several notable discoveries. One of the significant findings was that the demonstration that chronic and acute myeloid leukemia may arise in separate stem cell progenitor cells. Why is this important?
Well, I think it's important to know how cancer changes the normal behavior of a tissue system. And it's important to know where it comes from and how it develops. And with that knowledge, you can understand how you might be able to target it when it develops as a full-blown disease, but also it provides the basis for working out how it develops. And there's this concept of earlier interception now, where you can intervene earlier in processes. And if you know the cell that is giving rise to the problem and the cell that causes relapses of disease, then it's easier to try and target that cell and to potentially eradicate the leukemia. So we need to sort of understand how the hierarchies of normal blood formation are aberrant within leukemias, and that helps us to think about how we might target leukemia stem cells for better eradication and what I was talking about, which is trying to improve cure rates.
Another milestone in your career is that you describe what is the essential role for BET, transcriptional regulators, in AML. Are BET inhibitors now a novel therapeutic approach? Are they being used?
So the BET proteins are transcriptional regulators, and they're involved with various stages of transcription. Cancer cells are addicted to them. So they're obvious targets. Like a lot of these transcriptionally active proteins, they are important for cancers, but over a long period of time. And as single targets, the inhibitors have been not particularly successful, but they're now moving into combination studies, and my hope is that they will be much more successful there.
You have also done work looking at the cell of origin of malignant lymphomas. What can you say about this?
We performed a study to look at one of the mutations that is associated with a number of forms of lymphoma called CREB-BP. Like the BET proteins, it's again a transcriptional active protein, and it has a number of functions. What we found was that if you lost the activity of this protein at different stages within B-cell development, that it had different consequences, and we could show that malignant lymphoma was only developed when it was lost earlier in lymphoid development rather than within mature lymphoid cells. And I think this fits with some of the data from human studies where it's suggested to be a very early and possibly even an initiating event. And again, it suggests that we should perhaps be thinking about targeting these earlier events in these earlier cell compartments. And that's what we're studying further at the moment, and we're looking into its effects to modulate metabolism.
So now you're looking how to target earlier stages of differentiation. In which ways then?
So we've been looking at studies to see how these diseases develop. We do a lot of studies which look at early mutations in leukemias and lymphomas and how these diseases evolve. Important processes have to occur to fully transform cells. And we've been doing a number of studies across a number of diseases which are trying to identify targets for therapeutic intervention, and then possibly to think about ways that we might intervene as early as possible. If you look across the majority of cancers, the earlier that you initiate treatment, often the better are the consequences. And it's not weird science to think that we might be able to significantly delay the progression of earlier diseases into more aggressive ones, or possibly even think about prevention of some of these hematological malignancies. And we're interested in that early biology and whether or not you can identify targets that you can think about intervening as soon as you know that there's an issue.
So for the moment, you're trying to understand what happens early, but there is not always then a drug or a treatment that will come out of it. You are very interested in the basic
Yes.
mechanism.
The majority of the lab kind of focuses on the mechanisms of why these things happen, why these diseases develop, how they change through that evolutionary process. But the way that I have trained as a doctor first and a scientist second, I think you always have that line of sight to the clinic. You're always thinking about not just a mechanism, but a potential target. We almost always try to make comparisons between malignant tissues, whether those are myeloid cells or lymphoid cells, and their normal counterpart. If we're looking at a leukemia stem cell, we're always trying to compare the differences with a normal stem cell. And we're looking to find things that are specific to the disease, because they're much likely to be better targets. You can't just target things that are required for normal stem cell function, or you'll just disable blood formation completely, and that's not going to be any better than the current chemotherapies that we use.
How does this research integrate with your clinical practice?
Yeah, in two ways. So first of all, my clinical practice is less than it used to be, given that I've got a lot of administrative duties nowadays as well. But it's always informed my clinical practice in terms of trying to think of better ways to treat people, more clever ways to treat people, thinking about better combinations for them. But I think it works in the opposite direction as well. I come out of clinic sometimes quite frustrated because I can't do things for people. So it makes me committed and motivated to get back to the lab and to try and work a little bit harder. Or sometimes you identify a problem from a clinical encounter and you think, that's very interesting. I wonder how that works. And that might give you a research idea for a next project, or it will inform the way that you deal with a current project. So I like the way that they work together, but it does make your life quite busy.
Do you have any specific example of something that you discovered in a patient that you wanted to understand and took back to the lab?
Well, there's lots of things. I mean, the most obvious one would be our group are becoming very interested in the development of resistance to therapies, particularly newer targeted therapies. And that's always really bugged me about why these patients develop resistance, because often with leukemias, patients don't die from the primary disease. They die because the disease comes back, and it comes back and it's more resistant. So I think that has informed a whole, perhaps a third of my lab work on resistance to therapeutics. And that has come from the frustration of seeing patients relapse continuously.
So you're a member of the European Hematology Association, EHA, and you're a very active member. You're in the executive board. How has EHA influenced your career?
I think in quite a number of ways. The first international conference I ever went to was EHA in Barcelona in the last millennium. The first conference that I actually gave an oral presentation was EHA during my PhD. I was very lucky when I came back from my postdoc in the States that EHA gave me some money at a time when I was setting up my own group, and that was hugely appreciated. All of the other people that gave me money had, I had to follow a very rigorous, you can spend it on this, you can spend it on that. EHA gave me the money and said, you do what you think is best to further your career. So that was both appreciated and the freedom to do what I wanted with it, which was something a little bit more risky that perhaps the funding agencies in the UK wouldn't have allowed me to do. So I sort of decided that I would, try and pay EHA back. I've sat in lots of committees and various organising committees for some of the scientific meetings, but it's great fun as well. So you you give, but you get back. And I think it's a very worthwhile organization, or, I probably wouldn't be doing half the things that I do. But yeah, so I've kind of grown up with EHA. I've been a member for, more than 25 years.
It has really been there for you during your whole career. It has helped you grow also being EHA by the connections or by...
I think it has, and it's given me a great kind of venue through the Congress to present my science. I've been lucky enough to give lots of presentations, so it's helped my career. It's very sociable. I mean, it's always nice going to a nice European city in the summer, meeting up with your friends. Latterly, when I've been more heavily involved in the organization, it's given me a lot of pride to have organized things. So yeah, it's been very enjoyable, but also rewarding.
So you have so many different activities because you are a clinician, although now a little bit less, but during your life you have been very involved with patients.
Yeah.
Also in research, I imagine in education, and also in all these societies, specifically EHA. Which one of these activities do you enjoy the most?
The science, definitely the science. I like the variety, and I get asked this quite a lot by younger clinician scientists, because it's quite difficult to try and balance all of these variable parts of your career. But I think it's good as well, because you don't get the chance to become stale, and you're moving from one thing to another, and particularly with medicine and with science, they work on completely different timescales. So in medicine, you can see a patient in clinic, see a patient on the ward, you can immediately help them, and you get a lot of satisfaction for that. In science, projects can take years, literally years, to read out. With both of them, there are peaks and troughs, but they work on different timescales, and I think they dovetail quite nicely, and they feed off each other. I do a lot of administration as well, and that can, again, be quite harrowing. But again, it can give you pleasure. I always say that it's very seldom that I'm having a bad day in the clinic, in the admin, and with the science. At least one of them is giving you some pleasure. I can certainly work a lot harder if I'm doing one thing, then another thing, then another thing, back to the first one. If I was doing the same thing for 10 hours a day, then I think I would find it both boring and tiring. But if you have variety, then I think it's interesting, and it allows you to sort of do a lot.
So you enjoy very much changing and the variety of
not all the time, but yeah, in general, you're not having a bad time with everything. There's always something that you can get satisfaction from, and something that you can feel that you've done a good job on.
So looking back at all this work, what would you recommend to a young medical doctor that is choosing their path now?
I think you've got to do things that you're passionate about. It's not easy, and not suggesting it is easy. So you really have got to want to do it, because it will be difficult at times, and you'll need to fall back on something that really excites you or drives you and motivates you. So I would always say sort of follow your passions. You've got to be quite disciplined with your time. Well, I do far too many things, and most people, they do research on one thing and they do more and more. I do this, that, and that, and that. But it's it's what interests me. So I've always done what I found interesting. So
I think what you do is closer to what I used to do, because I was working really in stem cells, and for me it was, how does this work? Those basic questions of what is the cell of origin, for me, is always what I'm thinking of when I see all these the new treatments or everything. Where does this come from?
The fact that these things keep on coming back, we're either not getting to the root, or they're just developing ways around it. So yeah, it both interests and annoys me in equal measure.
And now with all the tools to sequence everything at the same time, and with AI to compare this in a much more efficient way, are you advancing quicker?
I think we're advancing knowledge quicker than therapy, and unfortunately, the advances in knowledge let us know how oversimplified we've thought about the problems. 10 or 15 years ago, we thought of tumours as much more sort of homogeneous entities. Now we've got sort of cell biological hierarchies, and even if you look at things that are supposedly the same type of cell, you look at the genetics in them, they're slightly different. You look at the transcription within them, they're definitely different. You look at the proteins, they're even more different. So we're sort of dealing with a much more complicated problem than we had imagined. But, those advances that we've made in terms of knowledge are really translating greatly into new drugs. There's not that many of them that are complete step changes. I would say that things like CAR T cells and immunotherapy, they really are a whole new sort of modality. And they are significantly changing things. But they, again, are not curing everybody. We're catching up, but the problem's becoming more difficult as well because our knowledge is improving. I'm very confident that we can significantly improve on how well we're doing. And, what I was trying to get through was that we now know about how long a period these diseases develop over, and we thought they kind of happened. It was all kind of perfect storm, everything come together, and all of a sudden, bingo, you've got cancer. It's not like that at all. With blood cancers, some of these complicated ones can take 20, 30, 40, 50 years. And we can detect some of these pre-malignant mutations at earlier stages, and that gives us, I think, the opportunity to think about intervening earlier. Now, the difficulty is that patients will go 25 of those 30 years without a diagnosis. They're not patients. We don't really have a reason to look for these disorders, and they're not common enough for us to be able to justify whole-scale screening projects for them. So we're getting a better idea of the sort of natural history of these disorders, and we're also trying to work out how related they are, because you can have different mutations which probably do different things to the same cell from each other. We don't know whether or not they generate vulnerabilities within the cell, and then the aim would be to try and work out what those vulnerabilities are, and can we come up with therapies that are safe enough and non-toxic enough to think about giving them to people who are not yet patients. And there are significant ethical questions. There's questions about whether they should know, because we cannot tell them confidently what will happen. We can tell them what might happen. So we're at that stage where we know a lot, but we're just trying to learn a little bit more about how to predict what would happen, because not all of these patients with one mutation will go on to develop a significant disease. Knowledge is great, but it brings responsibility with it. It's easy to describe things, but it's difficult to tell what's going to happen thereafter. So we're at a great stage, but we need to know a lot more. We need to predict a lot better, identify the patients that are really going to do badly.
So is it each patient will have a unique cancer at the end of the day?
Even in relatively simple cancers like acute leukemias, which have between 3 and 5 mutations, if you catalogue all of the mutations within those patients and all of the other abnormalities that are non-genetic, it's not crazy to say that almost every cancer is slightly different. But we do know that some of them are very similar, And we take advantage of that through personalized medicine to treat the common single mutations, the common co-occurring mutations. If you really look hard with a magnifying glass, they will all be slightly different. And the genetic makeup of every patient will be different, and their background genetic makeup will dictate how they respond to therapies, and their lifestyles will depend on that, and their premorbid condition will depend on that. So there's a lot of heterogeneity that we need to factor in, but this sort of takes us into the area of personalized medicine, because it's not just personalized for the tumor, it's personalized for the way that the patient will respond, what other medical conditions that the patient might have. So there are tumor-specific and tumor-nonspecific areas to personalized medicine.
I'm thinking about AI because there's a lot of talk about synthetic patients.
Yep.
So with AI to create patients based on what a typical patient will be like with what we already know.
Yeah.
But at the end of the day, the point of a clinical trial is to see also the things that we don't know. If we're going to be basing our knowledge on something synthetic, we are taking out a lot of complexity that we do not master.
Well, I think that AI can be applied to any number of projects to improve our understanding in hematology that we can discuss. But in terms of synthetic patients, the area that they're most being discussed is to form the control group. Because in standard randomized clinical trials, even if you have more patients that go into the treatment arm, you always have a standard of care or a placebo. Now that means that, half of your patients or a third of your patients are actually not getting anything that might improve them above what they could get outside of the clinical trial. And so the idea of synthetic patients is to really have a standard to compare. So if you can generate that data synthetically, then that means that more patients can be treated. So I think that is a possible area that we can improve trial design. But there are not really any standards at the moment for what constitutes a good synthetic set of patients. And if you get your control arm wrong, then you can't see anything about the patients that are treated. So, you don't want to run a clinical trial that can say nothing just because your control arm is very poor. So I think it's an area of very active discussion and debate. The other people that we need to bring into that conversation very much are the regulators, because clinical trials are generally done to improve clinical practice, but they are often done with new agents to get them regulatory potential to be given as standard of care. And I think that, again, it's important that these trials, which cost a lot of money, and in my opinion, are always done too slow, we've got to do them properly, because there are not enough new medications coming in.
So you think, the synthetic patients will have a place in this control arm?
I think that they will do. It could be that there are some controls, but they are in some way synthetically increased in number to allow the statistical comparisons that are required. But I think it needs to be done through a lot of discussion, and I know that EHA is involved significantly in these conversations with European Affairs and the Health Data Steering Group, and these are discussions that are occurring with EMA, so the regulators at the highest level.
Thank you very much, Professor Huntley, for being with us today, for sharing your expertise with us, and thank you to all of you for listening, and please tune in for our next chapters.
Okay, it's a pleasure. Thank you.